So she's a 33-year-old female married and diagnosed case of valvular heart disease, severe DI and severe MR for past 2 years. 2 months back, she was diagnosed as a case of atrial fibrillation and is on warfarin for past 2 months. Now she admitted with the complaints of shortness of breath, function class 2, and productive cough for the past 3 days. Here she was diagnosed as a case of heart failure.
And what was on the examination in ECG? Issue was atrial fibrillation with fast ventricular rate. So here you have a young patient with a background of valvular heart disease with LV dysfunction.
Yes.
And right now with some infection,
Yes.
maybe an aggravator, and she is having atrial fibrillation with fast ventricular rate. Now, how you decide about controlling rate? In this pressure patient, what were the pressures at the time of presentation?
At the time of presentation, her blood pressure was 90/60.
So with low pressures as well.
First of all, we have mortality benefit drugs for rate controlling in heart failure. These are beta blockers.
Now, what we are discussing this scenario. 90-70 pressures with the background of valvular LV dysfunction with some infection, pulmonary edema, volume overload. Now,
in this case, we could use digoxin because he's.
But what you need to know before using digoxin?
We need to find a
renal function. Primarily, ideally, you should be knowing hepatic function, renal function, CBC, anemia, everything that is in relation to the scenario. Why in AF? Hepatic function is also important in AF. And you're going to decide about anticoagulation. So hepatic and renal function both are important when you are seeing a patient with atrial fibrillation for long-term management decision. But in this patient, now how will you give digoxin? Because right now we have seen you have just given IV digoxin, isn't it? So that's why we need to know what is the dose of digoxin acutely, up to which level you can go acutely within 24 hours, what will be your maintenance dosages, and would you keep this patient on digoxin or switch to beta blocker? When, how, and what's the benefit?
Sir, we have to achieve the target blood level of digoxin, which is 0.5 to 0.8.
Okay.
For that, we have to first digitalize the patient first 24 hours.
How you do that? Because in every patient you are not going to do 6 hourly dig levels. In हमारे setup में तो even you can't get 1 dig levels and its results within 24 hours. So whatever you have to do on your own assessment, rate levels, renal function and everything, and then deciding dosages according to response. So how you go about in this patient?
Initial digitalization dose is 0.75 to 1.25.
Okay, so how you start in this patient practically?
Well, we can give 0.5 mg straight away. And
I think 0.5 is a higher dose straight away. 0.5 is 1 ampule. 1 ampule is 0.5. So out of that 0.5 ampule, I personally believe in 1/4 to half initial dose you can give. And digoxin usually take time to act. And in between, take care of other things as well. Because that AF with fast ventricular rate is not pure rhythm issue. There will be associated things like infection, like failure. These all are also playing part in that fast ventricular rate.
in anemia and in infection, we are not going to control the rate because that will be a physiological increase.
No, but at least when you take care of temperature, you assume some controlling of rate. Once your patient is out of that pulmonary edema within 1-2 hours, you expect some benefit in getting controlling of rate. So, and in these 2-3-4 hours, your 0.25 digoxin IV will also act. So, first 3-4 hours, just give that bolus. Don't give 0.5 straight away. 0.25 means half of that initial and wait what happens with it. then subsequently maintenance few, and in between start, if your patient is cautious, start oral straight away. So in this way, some of the dosages in IV form, oral straight away, then according to the response of your patient, rate and general condition, you can wait and see. And if your patient is maintaining adequate pressure and she's out of failure as well, you can add on beta blocker as well. So that's why you're keeping your you can say account for all the things together. So personally, I use not more than 0.5 in first 24 hour along with 0.25 of that oral. So 0.75 milligram in first 24 and seeing the response, unless and until you have something else, frank shock, and you think that this is pure due to AF, you can even cardiovert as well your patients. So that's now what we were discussing at the bed. What's the difference between the two in terms of using? Because ultimately with 0.25 she got her rate control, her pressure is like 110, 120, and you see she's about to discharge. So would you keep this patient on digoxin or would like to switch to beta blocker as well, and how you do that and what's the benefit of doing that?
We have other good drugs as well. We are using digoxin to decrease hospitalization and symptomatic relief. It is not going to
Here because scenario was that because she was having low pressures and frank failure, that's why we opted transiently for digoxin. But since she's out of failure right now and is maintaining a borderline pressure, 100, 110 systolic, now what's the advantage of switching to beta blocker?
Sir, beta blockers will give resting control of heart rate as well.
No, resting control you are getting with digoxin. What's the difference between mechanism of action? Do we have juniors? Mechanism of action, ditch or beta blocker, how they act in terms of controlling rate?
Sir, this is sodium potassium pump blocker, and ultimately it increases the contractility of the.
जो मैं सुनना चाहता हूँ वो जवाब नहीं मिल रहा है. In terms of if you clearly you're asked difference of beta blocker and DIG in terms of controlling rate. Main first thing, sympathetic or parasympathetic?
Parasympathetic is with DIG and sympathetic.
So what parasympathetic? Increased vagal tone. So it's DIG is related to parasympathetic and beta blocker is related to taking care of decreasing sympathetic activity. DIG is increasing parasympathetic activity. So that's why DIG is effective during rest, not much effective during where your predominantly sympathetic activity is driving the ventricular rate. So that's why she's a young patient. ओल्ड होती है, बिल्कुल बिस्तर पे रहना है, वॉशरूम जाना है, आई स्टिल बिलीव इन डिच, और बहुत मुश्किल से जब प्रेशर बहुत अच्छे आ रहे होंगे, आई विल ऐड ऑन beta blocker along with it. Since she is a young patient and you expect her to do physical activity, and in that activity she will be having increased rate, maybe very controlled resting rate, but during activity. So then I'll try reduce the dose of DIG from 2.25 to 0.125 and add on a beta blocker and see how she is maintaining her pressure. And if ideally, if she is tolerating that, I would take the DIG off and kept for rate controlling beta blocker. But a number of times these valvular and severe LV dysfunction patient unable to tolerate good dosages of beta blocker. So at that moment, then you have to make a combination. There is a study right now, I don't know, bisoprolol along with DIG was used in heart failure patients, and it is giving benefit DIG in that sense, because you can't increase your dose of beta blocker, your patient is still having tachycardia, then some DIG and some beta blocker, a combination, and they do very well on that combination. But you have to be cautious about rate control, further monitoring, and renal function, potassium. Because most of the time your heart failure patients are on aldosterone antagonist, on furosemide. They can have both hyper or So you have to maintain a good balance of all these drugs which can affect potassium. Now that is about rate controlling and other things. What about anticoagulation?
Sir, we will calculate chest like score and
Yeah, because it's not pure MS. Only those who are moderate to severe MS or mechanical, where you don't need chest vest. But all other you need chest vest to decide about anticoagulation. Do you think she's high risk for anticoagulation? This patient? Why?
Sir, yes.
LV dysfunction. Female with one LV dysfunction. Is she hypertensive? No. Diabetic? No. Stroke की भी कोई history नहीं है. So she is just having LV dysfunction. So moderate LA is enlarged. Okay. So he has enlarged LA, which is an echocardiographic precondition for having increased risk of thromboembolism. So she will need. So what anticoagulation will you give?
Sir, we have rivaroxaban.
Yeah, we can give NOACs to these patients. Only MS and other we can't give. This is rheumatic?
Yes, sir. Yes, sir. Yeah.
Rheumatic MR, we will do
She-
child vest.
It's like mix MS plus
So-
MR, rheumatic.
Having MS as well?
Sir, mild MS.
Mild.
Much more polycystic.
But it's mild, so usually you have to calculate chat vest.